Hello, my name is Jacques Creteur. I'm the head of the intensive care department in Erasmus University Hospital in Brussels. And I'm very pleased to give you this talk on the effects of fluids on microcirculation. I have no conflict of interest to declare for this presentation. 20 years ago, we described microcirculatory alteration using a video placed under the tongue of septic patient. And as you can see, we were able to show that septic patients presented a profound alteration of microcirculation in terms of a decrease in percentage of well-perfused capillaries, even in patients well stabilized. As you can see here, the mean SpO2 was around 70%. We can now say clearly that microvascular alteration are commonly observed in patients with sepsis and septic shock. And if we go to the etiology of this microcirculatory alteration that we have in sepsis, we have to speak about the glycocalyx. The structure of the glycocalyx is made by a layer containing glycoprotein and glycolipid. The layer is placed on the vascular sides of the endothelial cells. And we know that this glycocalyx is very important and play a key role in microvascular and endothelial physiology. In particular, the glycocalyx regulates microvascular tone and endothelial permeability. Glycocalyx maintains an oncotic gradient across the endothelial barrier. Glycocalyx regulates adhesion and migration of leukocytes and also inhibits intravascular thrombosis. So we know from several years that the thickness of the glycocalyx is decreased during sepsis. This study performed in rats submitted to an endotoxin challenge show clearly here that the thickness of the glycocalyx was decreased in LPS animals compared to control. You can also assess the damage of the glycocalyx by measuring the constituents of the glycocalyx who are released in the blood during glycocalyx shedding. And for example, you can measure the heparan sulfate concentration in the blood. And in this study, there was a nice correlation between the concentration in the blood of heparan sulfate in different stage of the septic disease. As you can see here, going from patient with no infection to patient in sepsis, severe septic and septic shock, and clearly patient in septic shock presented the high value of blood concentration of heparan sulfate, meaning that in this kind of patient, you will have the major damage of the glycocalyx. Again, it seems that the heparan sulfate concentration were well correlated to the severity of the diseases. You can see here, for example, non-survivors patient in sepsis presented high values of heparan sulfate in the blood. When the glycocalyx disappear, for example, in sepsis, so you have naked endothelial cells here, and the leukocyte adhesion can occur, and also the platelets. So the platelets can be activated and form thrombi in the microcirculation. You have also here the possibility of extravasation of protein and fluid, meaning to what we call a capillary leakage syndromes that we have in sepsis. So all beside the alpha glycocalyx, we have of course other etiologies to explain why microcirculatory alteration are present in sepsis. For example, we have endothelial dysfunction with impaired sensitivity of vasoconstrictive, vasodilating substances. We have also an impaired red blood cell deformability. So the red blood cells are more spheric and they cannot be deformable as much to enter in the microcirculation. All those things will lead to what we can call the characteristic of the microcirculatory alteration that we can see in sepsis. And studies on human sublingual microcirculation in sepsis reports clearly in sepsis a decrease in microvascular density, a decrease in the proportion of perfused capillaries, and an increase in heterogeneity between areas. All those phenomena can lead to tissue hypoxia. And for example, here, if you have, if some capillaries disappear because they are not perfused anymore, you can easily understand that the diffusion distance for oxygen from the capillaries to the cells, of course, will increase. It has been well demonstrated in this experimental study performed on cardiomyocytes that submitted to endotoxin, an increase in oxygen diffusion distance. And all those phenomena, of course, will result in an increase in oxygen extraction from the remaining capillaries who are well perfused. What is also interesting and very characteristic to the microcirculatory alteration that we see in sepsis is the heterogeneity in perfusion. In this schematic view, you can imagine that this part of the tissue here above is well perfused and this is poorly perfused. In this context, the majority of the blood will go through the well perfused part of the tissue. And so in this context, if this part of the tissue is less perfused, the capillary PO2 will decrease to very, very low value. And those values can be, the capillary PO2 can be in fact lower than the PVO2, meaning that in this situation, the venous oxygen saturation can be high despite tissue hypoxia. And that's what we see, in fact, in septic patients. You will all agree that the goals of resuscitation of this kind of patient is, of course, first to restore adequate flow and pressure. We postulate by restoring adequate flow and pressure, we will restore and improve tissue perfusion. And at the end, we will make cells happy. The problem is that when we look at the pathway of oxygen transport, we always think in terms of convective transport, meaning cardiac output, arterial pressure, arterial oxygen content. But the final step of pathway of oxygen transport is more a diffusive transport. With this diffusive transport will depend on perfused microvascular density, perfusion heterogeneity, and capillary oxygen content. So in this context, it's easy to understand that in sepsis, you can have, in fact, a loss of coherence between macro and microcirculation. In fact, in this situation, any change at the microcirculatory level induced by a therapeutic intervention will not necessarily result in a change at the microcirculatory level. So what are the effects of volume expansion in terms of microcirculatory blood flow? First of all, to illustrate the loss of coherence, you can see here the study performed by the scientists in our department. And as you can see here, they give fluid bolus in critically ill patient. And as you can see, this fluid bolus induced a change in cardiac index, but there was no relation, clearly no relation between the change in cardiac index and the change in the perfused, the percentage of well-perfused capillaries. So in some patients, you have a huge increase in cardiac index, but no change in microcirculation. In other patients, you have a small increase in cardiac index, but a huge increase, increase in the percentage of perfused capillaries. It's interesting to see here that, for example, in patients who will respond to the fluid administration in terms of cardiac index. In responders, cardiac index mean that those patients will increase cardiac index after the fluid resuscitation. And in this study, we were able to show that only half of those patients will respond in terms of microcirculation. So there is clearly a dissociation between the macrohemodynamic effects and the micro circulatory effects when you give fluid. But what is interesting is that the change in the percentage of perfused capillaries will depend on the baseline situation of the microcirculation. I mean, if the microcirculation is really altered before fluid expansion, there is more chance to improve microcirculation when you give fluid. When there is no alteration of microcirculation, of course, there is no change to improvement because microcirculation is normal. And even in the study, you can see that in some case, when microcirculation is not altered, if you give fluid, you can even alter microcirculation and decrease the number of perfused capillaries. It's interesting to see also if you give fluid at the early stage of sepsis, or let's say after 24 hours, does it matter? In fact, is the effect different if you give it at the early phase or at the late phase? This is also a study that was performed in our department, and as you can see clearly, the white box disease patient include in this study at the early phase, meaning during the first 24 hours of sepsis, and the gray box where patient treated with fluid administration after more than 2 days. And clearly, only patients in which fluids were given at the early phase presented an improvement of the microcirculation, assessed here by an increase in the percentage of proportion of perfused small vessels. At the late phase, you can give fluids, and even if those fluids increased cardiac index, there was no change in the microcirculatory blood flow. It is interesting also to see what is the effect of fluid overload on the microcirculation. This study here performed in the Netherlands. They take more than 100 patients, and they divide patients with low CVP and high CVP. As you can see, mean arterial pressure was higher even if this was not statistically significant, but mean arterial pressure was higher in high CVP group. Cardiac index was identical, was similar in both groups. But what was interesting is that in patients in which CVP was high, meaning hypovolemia, PPV, so the percentage of perfused capillaries, was lower when there was hypovolemia. That's very, very important because, of course, if you increase CVP, you will increase the pressure at the end of the capillaries. And it could, of course, alter the perfusion through these capillaries because you will decrease the gradient between out and in the entry and at the end of the capillaries. So it can, in fact, lead to an alteration of the microcirculation. So please, as you will see, do not give too much fluid because in some cases it can alter microcirculation. As I told you before in this presentation, you can assess the damage on the glycocalyx by measuring in the blood the concentration of constitutive elements of the glycocalyx and for example, the heparin sulfate. In this study performed in 100 septic patients, you can see that there is a close correlation between the volume of fluids given in the first 24 hours and the concentration of heparin sulfate, meaning that the more you give fluid, the more you will have heparin sulfate in the blood, suggesting a more severe degradation of the glycocalyx and shedding of the glycocalyx. And in the same study, in a subgroup of septic shock patients, the authors here show clearly that the only independent factor associated with an increase in plasma heparin sulfate concentration was the volume of the cumulative intravenous fluids given during the first 6 hours. So, of course, this can be associated to the severity of the disease, but here this is an independent factor. So, hypervolemia, giving too much fluids, can lead to glycocalyx alteration and shedding, who can result finally in alteration in the microcirculation. It seems that the atrial natriuretic peptide plays a role in the link between hypervolemia and glycocalyx alteration. You can see here, for example, the authors here gave in elective surgery patient fluids to induce acute normovolemic hemodilution or volume loading. It was in elective surgery patient, and as you can see, volume loading results in an increase in atrial natriuretic peptide concentration, but not in acute normovolemic hemodilution. What was interesting in this study is that by giving fluid, the authors were able here to, beside the increase in atrial natriuretic peptide increase, they were able to show an increase in syndicin-1 concentration in the blood, which is also the syndicin-1, also a component of the glycocalyx. To go further, you can see here the study performed in isolated in coronary arteries in isolated Guinea pigs herds, and they perfused those herds with atrial natriuretic peptide. And as you can see here, the perfusion of ANP was accompanied by an increase in syndicin-1, suggesting a direct injury on the glycocalyx. And the injury on the glycocalyx of these coronary arteries resulted in an increase in endothelial permeability, with a positive change in transudet formation in those arteries. Sorry. It's important to understand also that probably the type of fluids can influence the response on microcirculatory blood flow. This study was performed in our lab on sheep submitted to experimental peritonitis, and we compared 3 types of fluid: lactate, ringers, plasmalyte, and normal saline. And as you can see, in terms of percentage of perfused capillaries on the left PPV, the PPV at the end of the experimentation was clearly lower in animal resuscitated with normal saline, suggesting a deleterious effect of normal saline resuscitation on microcirculation. Again, in our lab, in sheep submitted also to experimental peritonitis, we compare 4 types of fluids here: hypertonic saline, ringers lactate, normal saline, and hypertonic lactate. And here in this situation, in terms of sublingual microcirculation, here assessed by the sublingual PPV, you can see that hypertonic saline perfusion during resuscitation of those animals was associated with a better sublingual microcirculatory perfusion compared, for example, to ringers lactate, normal saline, or hypertonic lactate. The probably beneficial effects of hypertonic saline solution, again, normal or isotonic saline solution, was also illustrated by the study here performing experimental peritonitis in pigs. And what they observe here, when they use a laser Doppler flowmetry to measure ileal mucosal blood flow, they were able to show that the ileal mucosal blood flow was much preserved in animals resuscitated with hypertonic saline solution compared to isotonic saline solution. So in conclusion, and to give you some key message on the effects of fluids on microcirculation. First of all, there is no doubt that microvascular alteration are commonly observed in septic patients and clearly are associated with a poor outcome. Fluid administration can improve microcirculatory perfusion in septic patients, especially at the early phase of the disease. Nevertheless, the effect is highly variable from one patient to another one. Sepsis is characterized by a loss of coherence between macro and micro hemodynamics. In this context, it's important to understand that an increase in cardiac output following, for example, fluid administration will not necessarily result in an improvement in microcirculatory perfusion. And finally, it seems that the type of fluid may also influence the microcirculatory response to fluid administration. Thank you for your attention.